failure before the end of this. So we'll start with a question here. Which of the following speeds recovery of patients with the Guillain-Barré syndrome? And I'm sorry to tell your French teacher that this guy pronounced his name Guillain. So A, steroids, B, plasma exchange, C, intravenous immunoglobulin, D, A and C, so corticosteroids and IGIV, or B or C, either plasma exchange or intravenous immunoglobulin. So pick A through E here. Okay, well, good. We don't have a lot to cover here. This is the correct answer. By the way, I took the recertification exam in the spring, and I obviously can't tell you anything about the content. I will tell you, however, that there are no more of this kind of question. On the other hand, because it's now a computer, some of the answers go A through H, so that there are a lot of choices you could make. So we'll talk about the reason for this, but either intravenous immunoglobulin or plasma exchange is the correct answer. So there are different kinds of respiratory failure. We're only going to deal with what Wood is classified as either 1 or 2. Oxygenation failure we'll spend a little time on, but mostly ventilatory failure. This is a trouble with gas transport. In neurologic patients, this is typically the same things you see in other people. So they have neurologic disease, but they also have cardiogenic pulmonary edema, or they have some parenchymal pulmonary disease. They can have a VQ mismatch or shunting, but they could also have neurogenic pulmonary edema. If we move on to the ventilatory failure, it's basically either failure of central drive or failure of effector mechanisms. The failure of central drive is going to result in an immediate increase in CO2 and a fall in pH. One of the things to keep in mind, by the way, when you're analyzing these patients is that the PCO2 is really not important. It's the pH that's important in terms of ventilatory drive. So if you're starting with an abnormal bicarb concentration, the PaCO2 is going to reflect that. You don't want to worry about it. You only care about the pH in terms of drive. So you could classify them in terms of the external part based on where it is. I don't think it's important to remember the type letters. Basically, you're starting at the output of the medulla and moving down through the nervous system out to the muscles. So in neurogenic ventilatory failure, for example, with cervical spine injury, keep in mind also that CO2 production may be increased. So not only are you having trouble clearing what you would normally make, but you may have an increase in production. This might also be a problem if you overfed somebody, but of course nobody overfeeds anymore. So if the neuromuscular system is intact, meaning that everything below the brainstem can respond normally, if you have an increase in CO2 or a decrease in pH, that's going to trigger an increase in minute ventilation. However, because of the neuromuscular problem, the tidal volume can't be increased, and therefore there's an increase in frequency. Now, this increase in frequency, to begin with, may not take you out of a range that you think is normal. And of course, if the patient is out on the floor, the respiratory rate is 12 unless they're dead. Doesn't really matter what they're really breathing at. So you need to look at the patient yourself and not take somebody's report about it. On the other hand, if it's a central problem, the PCO2 will start to rise immediately because the sensing mechanism is what's screwed up. In the peripheral patients, the rate starts to go up. They can keep their PCO2s and therefore their pH within the normal range for a long time. But once the vital capacity gets below about 12 mLs per kilo, they're about to fall off a cliff. They won't be able to increase the rate much more at that point, and they will very abruptly go into hypercapnia and acidosis as a result of it. So they're going along, increasing the rate, keeping the pH relatively normal. And in fact, early on, because of a sense of dyspnea, they may raise the rate higher than necessary and go through a period where they're slightly alkalotic. That's actually a bad sign in the person who is worsening, because that suggests that they're not getting adequate stretch and that they're moving into the time when they're going to have hypercapnic respiratory failure. So you don't want to wait for the PCO2 to reach 60 or the pH to reach 7.2 before you decide to intubate. We can use an anatomic classification, as I just showed you. You could also look symptomatically. So does this person have a focal problem? Do they have a spinal cord level? Do they have a diffuse disorder, which is purely motor, such as myasthenia, or sensory motor, such as you see with Guillain-Barré? This is the classic Plum and Posner description of the central phenomena you see. Here's someone with bilateral hemispherical dysfunction who has Cheyne-Stokes respirations. If we go around the hospital, the commonest cause of Cheyne-Stokes respirations, though, is congestive heart failure with a prolonged circulation time, rather than being simply a consequence of bilateral hemispherical dysfunction. This B pattern had been described in the past as central neurogenic hyperventilation, related to lesions here either in the lower midbrain or upper pons. In the second edition of Plum and Posner, they called it the same thing, but then they said, and now that we can do blood gases, it's interesting that these people are all hypoxic. In the more recent editions, they've recognized that these lesions produce neurogenic pulmonary edema, and if you fix the hypoxemia, the respiratory pattern goes back to normal. The person who really has central neurogenic hyperventilation typically has an increase in intracranial pressure that's global. It's tempting to think that they're trying to blow off their CO2, but in fact there's no known mechanism by which they would do that. And the person who is tachypnic with increased ICP is usually making themselves very alkalotic. These other patterns related to lower brainstem functions, apneusis, cluster breathing, and so-called ataxic respirations, won't support ventilation, so intubate first and ask questions later. All right, our next question. Acute dyspnea in a patient just admitted for a C7 spinal cord injury most likely represents A, an associated airway injury, B, parasternal intercostal muscle weakness, C, diaphragmatic weakness, D, aspiration pneumonitis, or E, pneumothoraces related to their accident. So go ahead and vote. All right, so I'm with the 36% here. The parasternal intercostals are necessary to keep the chest wall stented out when the diaphragm descends. Otherwise, when the diaphragm descends, the chest wall just falls in and there's not really much in the way of air movement. And you've undoubtedly seen this in patients who are weak. When you look at them and they're supine, the diaphragm contracts, the belly comes up, but the chest wall sinks in. You know just from looking at people like that they're very ineffectively breathing. The chest wall and belly both need to rise when the diaphragm descends in order to generate a decent tidal volume. Well, the parasternal intercostals are coming off of the upper thoracic roots. The patient with the C7 lesion has normal C4 output, and therefore there shouldn't be anything wrong with the diaphragmatic contraction. And their dyspnea is related to the fact that they're having the sinking in of the chest wall when they try to breathe. That's not to say they couldn't have some of these other things, but it's most likely this. So a lesion at or above C4 will paralyze the diaphragm. Between C4 and T8, you'll have varying degrees of parasternal intercostal weakness. Obviously, if you're down at T8, there isn't going to be very much of it. You probably won't notice it. You could have failure from a diffuse disorder like tetanus, in which all the muscles are in spasm and you can't ever relax them in order to recontract them. Or you could have an anterior horn cell problem. ALS, of course, is the prototype of this. The myelitis associated with West Nile disease, which looks just like polio, and in fact is a poliomyelitis, can produce this. And by the way, we're having a big spike in West Nile mosquito population positivity, and we've just started to see dead birds in the Chicago area related to it, so a human disease is not far behind. There are a number of peripheral nerve disorders. We won't cover all of them, but when you see a patient with respiratory failure who has a peripheral nerve cause of it, typically because they have either absent or diminished reflexes or because you've gotten your EMG colleagues to show you that it's a peripheral neuropathy, you need to run down the list and make sure that you don't forget things. I've actually had 2 patients in my life who had arsenic intoxication who weren't diagnosed with their first episode of presumed Guillain-Barré, but when they recovered, went home, and came back with it again, we were able to make the diagnosis. In general, the management of Guillain-Barré syndrome is really good ICU care, the prevention of ventilator-associated pneumonia and venous thromboembolic disease, good nutrition. Since respiratory failure is now not the cause of death in the vast majority of people, autonomic dysfunction is. Immunologic management is really the most important thing in speeding recovery. It's usually a cross-reacting antibody, sometimes against something you can determine, for example, like Campylobacter, often though we don't know what the actual antigen is. The effective therapies are aimed at removing the antibodies. Steroids turn out not to be very useful, except in the patients who have severe neuritic pain, where a couple days of steroids may markedly improve their symptoms. Plasma exchange has been tested against IgIV, and if you do it rigorously, there's no difference in the outcome. But the measure here is the time to independent ambulation. Right, so it's not, in most people, going to be a magic bullet where they're on the ventilator today and they go home tomorrow. Instead, however, of taking 6 months to get back to independent ambulation, they only take 3 months. All right, so you're in it for the long haul. Most of the patients will make recovery within 6 to 12 months. That's quite good, but I still have a few people who remain on ventilators at least at night years later. Therapy needs to be started within 14 days of disease onset to be effective, and the earlier you treat, the better. If you're doing plasma exchange, typically you'll do 5 exchanges over about a 10-day period. Could you do it faster? Probably, but whether you're going to have the same effect is not clear. There are folks who want to give a second course of plasma exchange if the first is ineffective. That has not been demonstrated to be useful, and if you think about the large group of patients, you'd be starting the second course well after plasma exchange has been demonstrated to have any effect. A French cooperative trial started patients on therapy when they were still ambulatory. It didn't really matter how many they got, as long as they got a couple treatments, they were fine. If they got started when they were already bedbound, 4 treatments were better than 2. In the ventilated patients, 6 were no better than 4. So 5 treatments seems like a reasonable thing to do. Otherwise, if you give IgIV, this randomized trial, which was the largest one that looked at this issue, did not show any difference in outcome between the 2 therapies. So I tend to pick based on the expected side effects. If I have a young person, I'll typically give them IgIV. Older people in whom the hyperviscosity of the IgIV might lead them to have strokes or myocardial infarctions, I'll tend to lean toward plasma exchange. But the important thing is to start the therapy as early as possible. So if you're going to wait 2 days to get plasma exchange, go ahead with the IgIV. Following IgIV after plasma exchange showed a slight but insignificant statistically difference here. They didn't do it the other way around. If you've taken off the plasma exchange, if you've given IgIV, you probably don't want to just take it off again by doing plasma exchange. I'm going to finish up with critical illness neuropathy here. This is an exceptionally common disorder that's often underdiagnosed. If you do electrophysiologic studies, you get about 60 to 70% of patients showing abnormal peripheral nerve function in the setting of sepsis. About 20% of those patients appear to have part of their ventilatory dysfunction related to the peripheral neuropathy that's produced here. I'm going to go through these quickly because we're out of time. The one I did want to mention, though, is that, let's see, this one. So this was a study that was done at Detroit Receiving Hospital. In this group of patients, out of 38 patients who had a neuromuscular problem causing failure of ventilatory weaning after sepsis or other critical illnesses, 25 of the patients had a critical illness neuropathy, but they did find other things. So it's worthwhile to actually study them and not just assume that you're dealing with a critical illness neuropathy. The other thing to keep in mind is that there's a more recently demonstrated syndrome that's really a primary muscle conduction failure that seems to be related to problems with calcium entry into muscle. And the way you diagnose that is by actually putting a needle into the muscle and trying to stimulate it directly. If you have failure of nerve or neuromuscular function, you can still stimulate a muscle, but in this circumstance it won't stimulate. So all these have been lumped together in the diagnosis of acute quadriplegic myopathy, but it's important to look for the depolarization failure one because these people look as though they have the axonal form of the critical illness neuropathy from which they're not going to recover for months, and yet 3 days later they're back to normal. So if your EMGers will do this study, which some of them will, and many don't understand how to do it, you can at least prognosticate that some of these patients are likely to do better than others. So I'll do one more question here. Which of the following may precipitate ventilatory failure and myasthenia? Steroids, aminoglycosides, macrolide antibiotics, calcium channel blockers, or all of the above? So go ahead and vote on this. Is our voting working? Okay, well, I'm with the majority of you here. Steroids often worsen strength initially when you give them to patients with myasthenia. The mechanism for this isn't clear. I've always imagined that there are plasma cells full of receptor antibody that get lysed by the steroids. But nevertheless, it's an observation that is important because you don't want to start somebody on steroids and then send them home. They may end up on the ventilator, or if they're not found at home, they may be dead. The aminoglycosides, macrolides, and calcium channel blockers all work by decreasing calcium entry into muscle, which is already pretty marginal. And every time there's a new macrolide, they tout it as, oh, this one's okay for myasthenics, and then within a couple years, it's either just listed as a warning, or now some of them even have black box warnings related to the use of macrolides in myasthenic patients that they'll worsen them considerably. We had a series of patients when azithromycin came out who ended up on the ventilator because they got a Z-Pak. My final comment here is, although you have to understand the concept of a cholinergic crisis, your patient is not having a cholinergic crisis. Your patient's having a myasthenic crisis. But nevertheless, as opposed to our old treatment, which was just to try to give more and more pyridostigmine to try and increase the amount of acetylcholine in the synapse, immune therapy is really what's important for the treatment of myasthenia rather than trying to get people more pyridostigmine. And there's a few other things in here you can read. I will skip over the botulism part for now. Just suffice it to say, don't forget botulism when you think you're looking at these neuromuscular respiratory failures. I've a couple times been quite convinced that I was dealing with the Guillain-Barré syndrome until the electromyographer showed me that, in fact, the patient had this sort of an increment in neuromuscular conduction with rapid stimulation, which is diagnostic of botulism. So it's important to think about this as a differential when the patient comes in with diffuse weakness, especially if it starts in the cranial nerves. And with that, I thank you very much.